Welcome back to Care Decoded, where we turn the complexity of healthcare data into clarity and better care. I'm your host, Sunil Nihalani. I'm the CEO of Inferscience. And today we are diving into one of the biggest promises in health tech, which is interoperability. Everybody talks about it, but few explain what it really means in practice. So joining me today on the podcast is someone who lives and breathes this topic, Brendan Keeler, better known as the Health API guy, whose inputs I read with a lot of interest. He's led integration work at Epic, and he has held product strategy at Redox, Zeus Health, and FlexPath. And now he leads the interoperability practice at HTD Health. Brendan, welcome, and great to have you decoding with us today.
Yeah, I'm really psyched to be here.
Great. Thank you. All right, so let's get started. So we'll start by talking about the why behind the work. So you are one of the go-to voices on healthcare data exchange. But before you were the health API guy, who was Brendan? What brought you into this messy, fascinating world of interoperability?
I needed a job out of college and was scrambling as something fell through. And my friend said, "Hey, why don't you come work for Epic?" I'm like, "Oh, cool." The video game, that was not what was in the cards. So I moved up to Madison, worked for Epic. They were going to put me in a basement in like the dungeon in the tundra of Verona, Wisconsin. And I said, no, I want to be in the field. I want to be interacting with people, even though I'm technical and a computer science degree. And they assigned me to the integrations team, the EDI, electronic data interchange team. And that set the course that I've been on since.
So was there a moment or project where you thought, yeah, this is broken and could do with improvement. I want to make it my mission?
There's always been something compelling. I was supposed to be a doctor. My dad is a doctor. My granddad is a doctor. I come from a long line of doctors, actually a long line of urologists, if I'd be very specific. Yeah, I'm like a third generation urologist. But I tried to do organic chemistry and bio and some of these things. I was like, oh, I actually did a internship at Penn with some twin doctor cardiologist and sheep hearts and stuff like that. And my twin and I'm actually also a twin. We were like, oh, like this ain't it. And just because blood. And yeah, but I've always been motivated. I've seen the journey of my father who just retired. He started in a 3-doc practice, urology outpatient practice with my granddad. It was, it grew and he became president of it, became South Jersey Urology. That was bought by Summit Health, which was bought by Walgreens. And so part of the journey, part of the narrative, I think that's important for me is that consolidative effect in America that we see. And that underpins a lot of the frustrations in my mind that people have with both healthcare and healthcare technology. If you, for instance, resent my old employer over a decade ago at this point, Epic, you might point to Epic and say, why are they so evil? But you might also point to their dominance as a function of consolidation. They're strong in large integrated delivery networks. And so maybe we'll get to that later in the podcast, who knows? But there's so many trickle down pieces that come from consolidation that I think lead to the broken effects we feel.
Right. Yeah. No, I think there's a lot of corporatization in healthcare. I've personally experienced that. So, and I think at the end of the day, it's probably not best for the end user, the consumer or the patient, but that is how it is. So anyway, that's just my 2 cents worth. Anyway, so if your younger self could see the interoperability wars now, what would surprise him the most?
I mean, 2 things. One is how far we've come. People point to where's interoperability? And that is the human condition, to look like a year in the past and say, why haven't we fixed something? But to continually improve is how we operate. We build ubiquitous highways and roads, and then we say, why haven't we built trains? We build train systems and we say, why isn't it cheaper? Why isn't it faster? And so, we'll always reinvent technology to question and improve, because otherwise we're static, and that leads to decay. And so where have we come? Well, when I started, ubiquitous or nearly ubiquitous clinical data exchange between hospitals was not a reality in 2012. And over the course of the last decade, by the end of 2020, we have Care Quality, Commonwealth and Health Exchange, and now TEFCA, all sort of linking together to provide 75-80% of coverage of providers nationwide able to query and retrieve clinical data from one another. Is it perfect? No, but we've already asserted, at least posited, that it will never be perfect. It is a very unique capability if you compare it to other international locales, other countries. And so by that metric, we've come so far. And now we're at a very messy phase where people look. I think the other thing that would surprise me is like, wow, we did that. How the heck did we do that? It seemed like it couldn't be done. And now angrier than ever because other people want to use that network for things we didn't design. It was designed for transfer of care. And now people say, well, that's those rails you built, that technology, that would be great for payment. That'd be great for operations. That'd be great for legal. That'd be great for life insurance. And they are not wrong, but that is not what it was designed for. And it breaks the assumptions that are baked into it today, forcing change, conflict, and strife. And I never could have guessed we'd have so many disputes, so many lawsuits, so much tension as we do at this moment in time. That would have surprised me. And the last thing would be, I don't think I would have ever guessed I'd still be in healthcare interoperability, but such is life.
Such is life. Well, I mean, as we build, you've encountered situations and problems that you never thought of before. So it's just an ongoing thing. That's life. So anyway, so let's move to where interoperability is today and what is the reality check. So from my perspective as a healthcare provider, the ideal situation for clinicians is that we should be able to see all the data pertaining to a particular patient. So if I'm seeing somebody, they've been up north the last 6 months, they've had a couple of hospitalizations, I should be able to see the data from all those places, right? And in a reasonable format, not bunch of garbage that you have to scroll through, right? So how close are we to achieving that goal, you think?
Well, I mean, it's very hinted at it, like 75, 80% of providers. So Epic, Oracle, eClinicalWorks, Athena, Meditech, the big names, the brand name big EHRs are all participating and have for a while in these nationwide exchanges for transfer of care. And so from that perspective, percentage of providers participating, we're doing pretty well. Another metric is data depth, right? How much of the longitudinal record do we actually have? And there it starts to get fuzzier. Because some of the groups like Epic, Oracle, the big EHRs, they share a ton. They share the patient level summary. They share the encounter level summaries with notes and labs. They share specialty specific data for oncology, for obstetrics. They share any PDFs and GIFs and TIFFs stored to the chart. You know, they're not always in the chart. They're sometimes in a document management system or PACS, which are not part of the most EHRs. So they share a lot, almost overwhelmingly so. But in my calculus, it is better to share more and filter than to not share and not have any access and have to go, chart chase. That is the bigger EHRs, but many do the bare minimum or less. So the smaller EHRs, they do just a patient level summary with PAMI, problems, allergies, medications, immunizations at a patient level, and not the encounter level stuff like notes and encounter diagnoses and things like that. And so less data. And then there's newer groups that have joined the networks, our tech-enabled care providers and sort of these eccentric new models that say, well, I just want to funnel all the data into my models. What's the bare minimum I can do in order to do so? And they go, and I'll put one new diagnosis back in there. They don't contribute very much back, but they take a lot and they do good. It's not to say it's never about someone not doing, like, pursuing a moral or ethical good. Most people are in some fashion, some viewpoint. It is about, if you're viewing, do we have a longitudinal record and you contribute one diagnosis, you're not contributing very much back to the longitudinal record. And so we see a variance in data depth across that provider suite. And then the killer part is that so much of healthcare is not the big EHRs. So much of the smaller specialty specific PT, oncology, behavioral health specific EHRs, one, don't participate today in the networks. Two, are not certified. So data access, even if I'm an application that wanted to go and sell to the PT provider and plug into Prompt or WebPT or something, they may not have the APIs because they're not federally regulated to do so. And so they have a lot more leverage to push back and like, get out of here, or you can't connect to us or scrape us or have any means to access data and thus participate in the networks. And so one of the gaping holes in policy that's existed for 2 decades since meaningful use are the boundaries of the certification program, which are still very voluntary, aside from the biggest EHRs that must do it to tie into the MIPS program.
Right. Yeah. I would say from the ground level, right? For someone who sees patients every day, and we have eClinicalWorks and we are supposedly connected to all the networks, it's a very hit or miss thing when I see a particular patient, right? Even though they might be on Epic, whichever provider they saw before were on Epic or one of these large EHRs. These are big groups we are talking about. Doesn't always come. I'm not sure why. And sometimes you open it and it's just a blank white screen. I've seen that many times also. So I think there's definitely some work to be done. I think theoretically, as you said, 70-80% practices in these networks, but I don't know that data really flows as smoothly as it should.
Well, there's the last, you highlighted a good piece that I just sort of glossed over, which is implementation details, right? Like the pipes are built, the wire, let's actually use a different analogy. Let's go through all the network analogies as we can on this one. The telecom networks. Do you have perfect service everywhere? Well, everything's connected, hypothetically should, but you have different on-ramps, you have different, use AT&T or Verizon or Google Fi or whatever, virtual network you might use. That has meaningful effect as an implementation details affect your experience of using ubiquitous networks and pipes that should be fairly uniform. And so, that is one reality, that your experience of that connectivity will be drastically different in Epic versus eClinicalWorks versus Zeus Health or Particle or any experience, has invest different amounts into fixing errors, making sure they can retrieve reliably, the reliability of using that network, visualization and embeddedness within your workflow of surfacing the contextually right information. And so you see actually different eras of, first it was just like, okay, sweet, we have these CDA documents, these continuity of care documents. Let's just have a tab that says, here's the outside documents. That was fine until it was great. Like people are like, wow, this is cool. And then they're like, wait a minute, now there's too many of them. And I, as a doctor doing my visit prep, cannot possibly click through 30 documents to find the needle in the haystack. So then there was the next era of investing into, how do I merge the outside data, which may be duplicative, right? Duplicative diagnoses, immunizations, whatever, with my own record in a way that's seamless. Advanced EHRs have done so, of sort of just weaving it in so that it's side by side with the internal data. That was phase 2. Phase 3 is, like everything, AI. How do we take that overwhelming corpus of data and say, here's the things that apply to me as a, someone who cares for geriatric patients or someone that cares for kidney, care patients. Very different parameters of what I care about and need surfaced to me. And so AI is actually enabling these visit prep apps as well as EHRs to surface nice little, here's what you need to know based on outside and inside data that suddenly you're not even knowing that it necessarily where it came from. You're just using it in the way that you need to accomplish the type of care that you or anyone else is trying to provide. And I think that's cool. It just means that you still may be using an EHR or a tool that's stuck in the, let me show you outside documents world.
True. Yeah. And speaking of the AI tool, so we have actually a little plug for ourselves at Inferscience. We have actually built that AI data summarization tool, which does exactly that, extracts all the data and nicely organizes it so you can see it all in one UI and deduplicates and all that. So I'm sure there are other apps like that as well.
We call that the alley-oop right there. The alley-oop is what just happened right there for the listeners, where I toss it up and he did, unintentional, but true. Like you guys are a great example of using outside data, merging with a chart, surfacing things for a job to be done in a way that most EHRs are not doing well today or not doing at all.
Exactly. But, you mentioned 75 to 80% of practices or physicians are on these large interconnected networks, right? But in terms of getting to everybody in there, so what are sort of the tailwinds and the headwinds, including any regulatory efforts to get everybody on that?
It is very timely that you asked this because literally today we had a tailwind, a huge tailwind that's worth noting. So what are a couple of this year, or the past 2 years? First is crisis. So we had the Epic versus Particle dispute and the Particle versus Epic antitrust lawsuit and numerous other disputes that have occurred within the networks that have been catalysts for more rapid change. The networks had grown tremendously over the past decade, but changed very little in terms of policy and technical changes. All of a sudden, accused abuse and fraud on the networks has catalyzed the reforms and the policies and the technical changes that are needed to advance the ball, both in terms of new use cases, fire and new data sets, right? New standards, and just moving as the world changes around us. So that's really cool. 2, TEFCA. So the Trusted Exchange Framework and Common Agreement, it comes out of the Cures Act of 2016, has been, the government looking at the private networks, Care Quality, Commonwealth, and Health Exchange, and saying, why have you not changed for a decade? Why have you not solved the problem? And saying, we are going to get more involved. We're going to step back into the ring after, they started with the National Health Information Network in the sort of the Bush-Obama era. They stepped back and said, let's let the private industry do things. And now with TEFCA, they said, we're going to get a little more involved to make new use cases, get us over to FHIR, have policy things happen for better or for worse. TEFCA is contentious because big government, But what is a practical outcome is that a new use case has been solidified beyond treatment, beyond that transitions of care, and that's individual access. So as a patient, since HIPAA, we've had the right to access our own data. We should not take for granted. It does not exist as a right in every country, as a consumer right, but it's been hard. I have to go and manually record retrieve and do those sorts of things. In recent era, you could use patient access APIs to access data and the username and password of your patient portal. That was hard for people that have many patient portals or never signed up for MyChart accounts or other patient portal accounts. And so looked and said, that's not good enough, because we want to have this world where patients have as easy of access to their data as providers do, so that they can have agency and individualism and all these rugged, idealistic things that we have as Americans, and maybe fix things proactively on their own. But if there's friction, they'll just say, that's too hard, and they'll just keep eating Doritos. And so, that has been a push under TEFCA. Now I can take my cell phone and I can identity proof with Clear or ID.me and use individual access services to pull my data without necessarily having to log into every patient portal. And so now that's been under TEFCA lighting up with Epic first, but now with Meditech, eClinicalWorks, Athena are all turning on these nodes. And so, a couple of years ago, I signed up for every MyChart in America as an experiment. And, I get like 30 or 40 different, patient records back that don't really have much in them, but, it finds my records with just this selfie. And so this huge change that comes from TEFCA and has been accelerated. That was last administration, really, that started to take off. This administration has pushed it further with the CMS aligned networks, the CMS health tech ecosystem, the CMS Make Health Tech Great Again. All are the monikers for this program that kicked off in the summer. And that is all about encouraging and pushing forward harder on patient access and further than even TEFCA had designed, with the CMS's muscle and weight, since they are significantly larger than the ASTP ONC regulatory body that manages health technology. They have historically $50 million a year that they manage or are allocated. CMS's a couple zeros more than that they could throw around. And so that is a voluntary program, but people see carrots and sticks looming in terms of what might they do next, or may they use information blocking. And all that to say is we've seen traction and growth as that encouragement has come from the CMS as today just a convener, perhaps an enforcer or regulator to come. And so that's a huge, 3 huge tailwinds. The fourth today, literally today, announced on Monday, the CMS Access program. So this is a new CMMI program, right? These innovative CMS programs to try new things, see what happens, miss about 90% of the time, but sometimes have big wins. This is a new one that people are really excited about. I would say that 85% excited, 15% cynical, which is higher than usual for a CMMI program. This is tech-enabled care businesses, the Omadas, the Virtas, the Hinge Health, the Headways, Headspace, that serve diabetes, behavioral health, kidney care, can all be referred to seamlessly in this program from traditional providers, PCPs and ACOs and such, and then collect outcomes-based payments for any outcomes they can affect in terms of reducing, diabetes and things like that, hypertension, while the PCP still gets a, sort of set regular payment for checking in on the progress there. And all of that is dependent on interoperability. All written into this are requirements to be participating in nationwide data exchange in one way or another, to be pushing back care summaries to the primary care provider via Direct Trust or another push network. So it's a huge boon for tech-enabled care businesses, huge boon for interoperability companies, for the underlying networks like Direct Trust that largely had been not as a focus in recent years, and maybe not as big of a boon for ACOs and other things that would love to just have more programs that focus on them. But there'll be innovative ways that those traditional organizations wrap in these tech-enabled care providers in order to access the Access program. And there's no way to see it but a tailwind for interoperability, because what is really notable is that what's not said is that these tech-enabled care providers need to use a certified EHR. They don't. It's not written as such. But it does say they need to do these interoperable things. And so very interesting slant to see, and very good for the nationwide network data exchange Less so for do these, technical care providers have FHIR APIs and things like that. That's not included in this program. But maybe more than you bargained for. But those are all the tailwinds, and there's a lot all happening at once. The CMS is very busy.
Sorry to interrupt you, but you mentioned the ACOs, right? That maybe not as much, but I think there isn't something in it for them, right? So if these tech-enabled services improve a patient's A1C, for example, right, or they increase the rate of health screenings. At the end of the day, the provider and the ACOs, they do get rewarded for better quality, right? So maybe in a tangential way, but it does help them as well.
Yeah, no, totally. I mean, just in a second order way, if they are smart enough to take advantage of it, which perhaps consultancies out there can help them do. Not pointing towards anyone in particular, but if we're going to sell some services, I'm here to do so as well. And so all this to say is there's a lot of opportunity for many organizations, and it could be very little in terms of this nice low base rate you get from checking things as a PCP, or it could be a lot if you participate more fully and see how you can really get into the program.
Sure. So we talked about the tailwinds. Any headwinds that come to mind? Do you see any?
Yeah, I mean, look, I just posited the disputes and such as this big tailwind, and they were in terms of catalyzing change. But the headwind piece is that these networks today are built on trust, right? They're built on you're a provider, I'm a provider. We're doing care. Let's exchange because it's better. And for us, and our sliver of the longitudinal record is only a sliver compared to everything else that is out there, even if we're Mayo Clinic or Cleveland Clinic or something like that. That trust, because of the disputes, is stretched and strained to a way that there's a low probability. But could people opt out? Could providers say, whoa, we got to reinvent the whole thing because this sort of blanket trust between organizations isn't strong enough to sustain our legal risks, to sustain the financial arbitrage that groups are doing to make a buck off of our patients. And so, that is the tension we see underpinning the disputes. And that, in a low probability way, could lead to the unraveling of networks. It's really hard to unravel a network. It's really hard for a network to fall apart because network effects are the strongest technological force for any product in technology. But it can happen through fraud and abuse that's not mitigated, fraud and abuse that just leads to opting out en masse. And so there's that headwind of, life insurance and legal and payers aren't accommodated and brought into the network formally or given a digital channel as ubiquitous and easy, then they're going to keep abusing the existing rules to doing backflips around the assumptions in ways that could cause the network to unravel. And like that low probability risk has a high impact, to say the least.
Yep. Hopefully that doesn't happen. So where are we from the regulator? We talked about TEFCA and, the main use patient care, right, in terms of the interoperability. But where are we from the regulatory perspective with regard to using interoperability and these networks for health plans and other entities who may not be healthcare providers?
That's the tension. Like underpinning the particle Epic, antitrust lawsuit and Epic particle dispute is servicing demand from payers, from life insurance, from lawyers who today they have to go and pay Datavant or chart chasers, $100 or $10 or whatever a chart for a hospital. And like that very manual, slow, expensive process, they look over and say, those providers get it for free. They get it for nothing. They get seamlessly digital instantly. And so they very rightfully say, how can we not use imagine there's a highway and you're forced to go and pay the expensive, slower road to go from New York to Philadelphia. You would go and you say, you know what? I'm going to pretend to be in this club and go on the highway. I don't blame demand for seeking better solutions. I blame the networks for not figuring it out. For the participants, the supply side participants, for being dumb enough to stick their head in the sand to realize that if they ignore it, they're encouraging fraud and abuse. They think that if they continually litigate the boundaries of treatment, that it will stop people from using the highways. They are wrong. People will find ways to get in because it is more efficient, cheaper. We've price set, which is typically a no-no in any industry or by the government. But we price set exchange to zero, right? The cost from provider to provider is zero. And so when you see that arbitrage moment, there's tons of people who either out of wanting to do good and solve problems or out of greed say, I can make a bunch of money selling to law firms who will pay $100. I could charge them 75 and make $75 a pull. And so that incentive, unless eliminated directly, will lead to continued abuse. And more, and none of this is necessarily illegal because they find good ways, they have good lawyers, they are literally law firms to insulate themselves around the boundaries of HIPAA, but doesn't mean it's the right way, and it opens up cavernous vectors of abuse for people that just say, I'm going to pull every patient on the network and sell it to pharma. Could easily happen through these sort of vectors. And the only real answer in my mind is to find ways to build the paved path to accommodate that, or demand will find a way to reach that supply that in a way that's cheaper and more efficient than the extremely kludgy manual processes they have today. And so the great challenge, the great crisis for these networks, for the leadership of the government and the networks and you and I and everyone involved, is to get over our trepidation towards payer-provider data exchange, towards these other use cases, and build ubiquitous digital infrastructure that serves them, or repurposes the digital ubiquitous infrastructure to serve them, or it will just keep happening over and over again. And so that's the practical, direct answer, but it threatens infinite business models that are predicated on $100 a query, a poll, or predicated on selling that data. If you're a supply side, if you're a provider, there's a trade to be made right now if you're a provider